Hi, I'm David Ridley. My guest is Dr. Vivian Lee. She's the president of Verily Life Sciences, an alphabet company, which is the parent company of Google. She works with the clinical and engineering teams to develop products to improve health. She previously served as Dean of the School of Medicine and CEO of University of Utah Health. She's a senior lecturer at Harvard and Massachusetts General Hospital. She's the author of The Long Fix, Solving America's Healthcare Crisis with Strategies that Work for Everyone. Welcome, Dr. Lee.
Hey, great to be with you.
Was there an aha moment early in your career in which you thought, this is why we need to change the system?
When I was serving as the chief scientific officer at NYU, so I wouldn't say it was very early in my career, maybe mid, I made a field trip up to the Mass General to visit a friend of mine, Greg Meyer. And he, at the time, was overseeing strategy and quality for that hospital. And I'd gone up there to learn more about their research infrastructure, because they really are one of the paragons of research, biomedical research. But he was really involved in improving the delivery of healthcare for the hospital. And he showed me their electronic medical record, which was homegrown at the time. And he told me about how the Mass General had actually completely changed the way in which it was getting paid for healthcare in working closely with the state. You know, typically they were fee for service. The more things you do to patients, the more money you make. But they had decided to do something completely different. Because of their electronic health record, they actually said to the state, look, why don't you just pay us if we're able to improve the health of our patients? If we're able to keep the blood pressure down for our patients with high blood pressure, or the blood sugars down for our diabetic patients, then you can pay us a little bit more. And if we're not able to do that, you pay us less. That was this incredible aha moment for me, because it showed me how hospitals could actually take the lead on changing the way in which our healthcare delivery system was going to work and was going to get paid for. They could actually use data to drive a lot of this change for the good of patients, right? The ultimate outcome is, are our patients actually healthier? And actually could create a win-win-win. It's better for the patients, better for the health system, because actually they were able, with their data records, to reduce those numbers and keep patients healthier, so they got paid more. And it was actually better for the payer, because the payer actually achieved better health outcomes and not just a whole bunch of additional bills for extra procedures. That was really an aha moment for me when I decided that I wanted to lead a system that could actually be very proactive about moving our healthcare system closer to value, to better outcomes and lower costs.
What's the first step for stakeholders to make high-value healthcare happen?
Well, there are a lot of different stakeholders. So I'd say that a common theme would be to first just recognize the problem, to recognize that we have to move to a higher value system, set that goal, and then really have the right tools to succeed. So one of the things that I try to do in the book is to talk about it from these challenges from the vantage point of people as patients and consumers of healthcare, clinicians, payers like employers and government payers and private sector payers, as well as policymakers. So there are multiple different perspectives, and I provide an action plan at the end of each chapter just to sort of highlight specifically what people may think about. So I'll give you an example for patients or for people, just the public. I think most people may not even fully understand how much they're really paying for healthcare. If they're fortunate enough to be employed and to have their employer cover their health insurance, they may think they're only paying $20 out of pocket, let's say, for a clinic visit, maybe some co-insurance if they have a hospitalization. But what they don't realize right now is that we're not only paying those co-payments out of pocket, we're also paying through our taxes for federal plans and programs like Medicare. But also it's really coming out of our wages. So over the last 40 to 50 years, wages have essentially been flat on average across the country, because while the economy has grown, the difference where we should be getting paid more is all gone to our healthcare. So recognizing the problem and then setting our own personal goals, whether it's embracing, more healthy behaviors, digital health programs, for example, but also recognizing that more is not better for us even. That we don't need antibiotics every time our kid has a cold or a cough. We don't need an MRI if we have a headache or back pain, as long as we don't have any neurologic symptoms. So recognizing more isn't always better, more costly isn't always better in healthcare. I think that's also our responsibility. So that's just one example from one stakeholder's perspective. And through the long fix, I talk about it, of course, from all the other perspectives as well.
You're with Verily, so you're surrounded by people in the tech community. What do people in the tech community misunderstand about healthcare?
What do they misunderstand? Well, I think there's a lot that is very difficult to understand about healthcare, whether you're in the tech community or not. And even if you're in the healthcare community, there's a lot for us to not understand or misunderstand. So that's a big question. I think one of the common misunderstandings about how healthcare runs is this notion, let's take just hospitals, that hospitals are like businesses in every other industry, where, let's say, the CEO makes decisions that are the most important driver of the outcomes of that business. And in fact, I think healthcare is very different because there are variations in the outcomes, because there are tremendous variations among people. And those individuals have a lot of influence on the outcomes. So, for example, if you have a perfectly run health system and you say prescribe just the right medications and just the right exercises after surgery, if patients decide not to do those things, that really significantly impacts your outcome. And also, I think the role of physicians and clinicians as independent agents. So they don't always view the CEO as necessarily their boss. And so how decisions are made and collectively, acted upon, very different in healthcare. I think healthcare just is a completely foreign language. We have so many acronyms, abbreviations, terminologies, and very complex web of interdependencies because our business model is just so complex. And then maybe a third example, and I could go on, there are just so many, I think, is that we are healthcare is a very risk-averse culture. This notion, in Google, there's this idea of fail fast. In healthcare, we don't fail fast. We really don't, we don't aim to fail. That's not really good for the patient. So, and because everything is a matter of life and death, literally, we're not as willing to change. We're not as willing to take risks, I think, as maybe in other sectors. And so innovation has a very different definition for us, I think, from the technology world. I'm not saying that this healthcare mindset is absolutely right. I think we need to loosen up a little bit in some domains, like the way we think about innovations that can be, in many aspects of care, innovation and actually can be embraced a lot more quickly, like we're seeing in COVID with telehealth, for example. So I think there's a happy medium between the technology sector and the healthcare sector once we can start to understand each other better.
You mentioned telehealth. Do you think some of the recent changes in telehealth will stick? Will we have more access to telehealth, and will reimbursement remain at those levels comparable to in-person visits? What do you expect for telehealth going forward?
Well, telehealth has been around for a long time. I'm a radiologist by training. I do MRI, and 25, 30 years ago, we were already starting to do some telehealth because we were able to, for example, transmit MRI scans from California or Michigan to New York to read. At that time, in order for me to do that telehealth, I had to get licensed in every state that those images came from. So I had to fill out stacks of paperwork, to get licensed in Michigan, licensed in California, and we've seen those burdens, those regulatory requirements just completely disappear overnight because of COVID, which I think has been very important. And also we've seen that people, both patients, but especially clinicians, I think have come to embrace telehealth in ways that I think we didn't expect that adoption could come so quickly. So I think there's some real positives to the development of telehealth that are beneficial not only in the COVID crisis, but of course beyond. I think the question about the future of telehealth comes down to, is telehealth going to be deployed and implemented in a way that recapitulates a lot of the existing shortcomings in the way in which the business of healthcare is carried out? And what I mean by that is it going to turn into another fee-for-service unit of service where there's a tendency to overutilize? Or is it going to be deployed in a way that's more value-driven? We actually talked a lot in the book. I talked a lot with folks who were running Medicare Advantage programs, these physician groups that were just getting paid a fixed amount of money per month, per year to care for patients in a kind of a global payment model or a capitated payment model, rather than getting paid every time they did something to people. And I think in that model, if you're just basically paying a group of physicians to keep somebody healthy, they can use telehealth as a very, very effective way of keeping in close touch with their patients, and use it, I think, with the right degree of discretion. But if it falls into that in that fee-for-service trap, then we will see payers increasingly want to deny that service, and we'll be back to where we were before. So I think it depends a lot on how we think about it, payment going forward.
If you were working on a health tech startup, would you want your CEO to be a healthcare person, like a medical doctor, or a tech person?
That's actually the same question that I'm often asked about, same kind of question that I'm asked about who should lead healthcare companies, for example, or hospitals, for example. And I think there the answer is the same. I think regardless, what you really want is an outstanding leader. And if they happen to be a physician, for example, as I am in this position, then obviously I will be very closely partnered with technology leaders as well, or vice versa. I think we talk in healthcare all the time about these leadership dyads, where we have a strong clinical lead and we have a strong administrative lead, for example. I think the same is true in health technology.
What's a program at Verily that you're especially excited about?
Oh, I can tell you, actually, there are a number of programs that I'm really excited about. I'll tell you about, let me see if I can contain myself to a couple of them. So one program that I'm really excited about is Onduo. It's our digital health solution. And it started a few years ago, really focusing on type 2 diabetes and really enabling people who have type 2 diabetes to manage their conditions at home, outside of the four walls of the clinic or the hospital. And it includes several really innovative components. So to start with, as you know, people who have type 2 diabetes, they have to prick their finger multiple times a day to check their blood sugars, for example. And instead of that, their technology is a continuous glucose monitor. We happen to manufacture one of these, but there are others also on the market. Maybe it's about this big, and you put it on your arm or you put it on your abdomen, and it measures your blood sugar continuously 24/7. And it has a little Bluetooth chip in it, so it transmits those measurements to your phone or your app. And so for the first time, people with diabetes are able to actually track their blood sugars continuously. And the most important factor there are the foods that you're eating or drinking or you're exercising. And so instead of having people take a food log and kind of keep a notebook, which they never do, you take pictures of your meals and snacks with your phone. And so now you can actually see what you ate for breakfast and see what it did to your blood sugars. There's a little extra telehealth in there, so there's a coach and a physician, so you can actually have that human interaction. And then everybody gets a little sprinkling of AI on top. And what that AI, artificial intelligence, does is it just knows some patterns for you. So you may see patterns, obviously, Vivian, you really want that extra slice of chocolate cake. Here's the last 3 times you had it. This is what it did. Sometimes it's kind of obvious, but other times it may not be. For example, when you have cornflakes and milk, actually you have a higher blood sugar than if you have, let's say, egg and a piece of toast. And so it can make recommendations. Or maybe soy milk is a little bit better than cream in your coffee for you, or those kinds of observations. And those are shared with the individual as well as with the coach and the physician who are working with you. Really transformative experience because it allows the individuals to do what has been called co-producing their health. And this is an idea that I think is going to be really important. This is going to be an idea that's going to be really important going forward, which is that people need to co-produce their health with their clinicians and other healthcare providers. And their responsibility is really the greatest outside of the hospitals and clinics, because it's really what you eat and how you exercise that determines your health. So that's a product that I'm really excited about. And we see, and others who do this also have very similar kinds of results, which is that the impact on health is as effective as almost any medication that I've seen. So that's one. Related to that actually is a product that we just recently built out for COVID, which is really, again, a digital health solution for people to actually, it's really for employers and for university administrators to help their employees and their students and their faculty and staff get back to work and get back to campus. And that goes with symptom checking, helps people test, get results back. And there's also some data science epidemiologic models, for example, that help employers figure out in that densely packed manufacturing plant that they are responsible for, those folks need to get testing more frequently than, for example, back office folks, and it really sort of helps them manage and track as a whole. So those two, I think, are products that that I'm actually really excited about. Can I tell you about a third one? Okay, a third one very quickly. This is really also, I think, a very innovative product, completely different. So now we're in the public health space and more on the prevention side, and has the best name of any project. It's called Debug. Remember, we're a tech company. It's called Debug, and it's all about eradicating certain mosquito-borne illnesses, particularly those carried by Aedes aegypti. And those include infections like yellow fever, dengue, chikungunya, Zika. And what our team has done over the past several years is basically taking advantage of a naturally occurring phenomenon, which is there's a bacteria called Wolbachia. It's one of the most prevalent bacteria in the entire animal kingdom. When Aedes aegypti, who normally don't have Wolbachia, actually are infected with Wolbachia, the males become effectively sterile. And in the mosquito world, only the females bite. So the way in which we've deployed this is to use AI to separate males from females and then release a whole bunch of males with Wolbachia. We started in California, Fresno, and now we have multiple sites, for example, in Singapore and in Australia. And now this Aedes aegypti, it was native only to sub-Saharan Africa. It was actually brought to the rest of the world through slavery, and so it's a species that is actually kind of taking over from the native mosquitoes in most parts of the world. So by eradicating it, I think we don't expect any significant ecological impact, but significant reduction in these infectious diseases. So that's another project that I really think is very interesting.
Those are fabulous examples. I'm interested in all of these. Regarding debug, is the idea that that type of mosquito would become extinct in the West or in the whole world?
Well, as I said, it's only endemic in this one part of sub-Saharan Africa. So it's actually it never existed in the rest of the world. So we're really only focused on the areas where it is transmitting and leading to high levels of these infectious diseases. Probably won't concentrate on other parts of the world, but in those areas where we have really measurable health impact, every year the number of patients who are hospitalized or even die of dengue, for example, in that part of Southeast Asia is pretty significant. So those are the areas that we're really concentrating on.
The next segment is overrated or underrated. It's an idea I copied from Tyler Cowen. I'll give you a word or phrase and you can tell me if it's overrated or underrated, and you can pass. Overrated or underrated? The Duke Chapel.
Oh, underrated. The Duke Chapel is such a special place. It is obviously such a special place for all Dukies. Did my residency, my internship and residency at Duke, so I have very fond associations of that chapel. Been to a few weddings there as well. I think when I think about the Duke Chapel, especially in this day and age, I think it's it's spiritual, it's a religious place, it's sort of, which is something so important to so many of us. And also it's a place, when everything seems like it can be replaced by virtual, that sort of real physical place and everything, I'm kind of getting chills down my spine just thinking about it, everything, that whole feeling of being there is so important. I wish I could be there now.
Overrated or underrated? Oxford University libraries.
Oh, underrated, I think also. The Oxford University libraries, they really have a special role. In the UK, every published book has to be put into the Oxford University Library. And it is transforming, so it's not just a physical space. Obviously, it's also physical and online. And I think it really serves as a repository of knowledge and learning. It's a wonderful institution.
Overrated or underrated? Littmann stethoscopes.
I'd say probably also underrated, especially in this day and age, because I'm a radiologist, and the number of times when now I feel like the residents or folks who send a patient over to us to image haven't even touched the patient. Before they even touch the patient, they send them over to some imaging study. And while it may be true that an echocardiogram or an MRI may be able to see detect valvular disorders better than maybe some people with a stethoscope, I think that we can never lose. We never want to lose that human touch. The art of medicine, the human interaction piece. So I would say underrated.
Overrated or underrated? Early morning rounds.
I would say overrated. I would go overrated on this one because I feel that even though early morning rounds are really useful for the team, obviously, for everyone to get together, the rounding idea is really important. I think waking up patients early in the morning, especially you're talking about early morning rounds. I remember pre-rounding when I was a surgical intern at Duke under David Saveston, and waking up a patient at 5:30 in the morning just to prepare for rounds, it just seemed so counter to this notion of us being focused on healing them, waking them up, because it was more convenient for us to do that at 6 or 6:30 than to allow them to sleep. So that one gets an overrated.
Overrated or underrated? Nap pods at work.
Nap pods. I'd never been introduced to this until I joined the Alphabet family and first set foot in the Google office. So I think probably I'm going to go underrated because I feel like sleep is so underrated in our society. In fact, I think my kids sort of get tired of hearing this from me, that if I had it all to do over again, I would have really devoted myself to research on sleep. I think it's so fascinating. There have been a number of books that have been written recently that I've really enjoyed a lot, and I think that we also should recognize that everybody's different. Our sleep cycles are different, and some people just need a little nap, and it makes them better. And so underrated.
I too am an advocate for naps, so that was definitely the correct answer. So this has been fun, Dr. Lee. Where can people go to find out more information about you, about your book, etc.?
Well, thanks for asking. You can find out more about my book on my website, and that is vivianleemd.com. And I try to keep some information up there. Love to stay connected with people. I'm working on a series and some short videos, advice to people who want to become doctors or advice to residents there, and actually put out some discussion materials also there for people who might want to use the book for book clubs or for the classroom or for pre-med gatherings, for example. And actually, we're even offering, let me see if I have one, we're even offering some bookmarks for people, because in this day and age, we can't do book signings, and people have asked about, sending books to friends and family. So on my website, we even actually have some autographed bookmarks for people for free that we're happy to send out. So hope people will stay connected through the website.
It's really nice that you have those resources for the pre-med students. One of those students, Elizabeth Gu, is a big fan of yours and gave me some good ideas for our discussion today. So I'm glad you're connecting with them.
Oh, terrific. I hope she connects out too. That'd be great.
My guest today has been Dr. Vivian Lee. Thank you, Dr. Lee.
Thank you so much, David.